Welcome to the series where I review the 2025 AACE consensus statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today, I want to walk through how AACE is asking us to think about obesity, not as a number on a scale, but as adiposity-based chronic disease, or ABCD. What the consensus statement really emphasizes is a shift toward person-centered, complication-centric care, and how that philosophy should guide screening and diagnosis in everyday practice. The first and most important shift AACE highlights is reframing the problem. The consensus deliberately de-emphasizes body mass index as the endpoint and instead centers the discussion on whole person health. Body mass index still has value as a screening tool, but AACE is very clear that body mass index is not the disease. ABCD is defined by excess adiposity and its clinical consequences. As a result, the therapeutic target is not weight loss alone, but improvement in health outcomes and quality of life through prevention or treatment of obesity-related complications, or ORCD. AACE also emphasizes who should be doing this evaluation. Patients with obesity or suspected ABCD should be assessed by an empathetic, trained healthcare professional who understands both the anthropometric and clinical components of the diagnosis and is prepared to follow the patient long-term. The consensus explicitly includes internalized weight bias and the impact of stigmatization as part of the clinical picture. These are not peripheral issues. AACE recognizes that they directly influence engagement, adherence, and outcomes, and therefore belong in routine clinical assessment. When it comes to screening and diagnosis, the AACE algorithm is built on two required components. Screening usually starts with body mass index, but diagnosis does not stop there. The first component is anthropometric. The goal here is to confirm the presence of excess adiposity, not simply to document an elevated body mass index. AACE recommends interpreting body mass index as indicative of excess adiposity and using ethnic-specific criteria when appropriate. Waist circumference and waist-to-height ratio should be measured and interpreted using population-specific cutoffs. And body composition, including muscle, fat, and bone, should be assessed when clinically indicated. The emphasis is on understanding adipose tissue burden and distribution rather than focusing on total body weight alone. The second required component is clinical, and this is where AACE frames ABCD as a staged disease. The clinician evaluates the risk, presence, and severity of obesity-related complications. This includes a medical history, weight history, family history, physical examination, review of symptoms, and basic laboratory testing. The consensus also reminds us to consider specific etiologies, including monogenic or syndromic obesity, endocrine disorders, and iatrogenic causes. AACE is very clear that disease staging is based on complications, not body mass index. Two patients with the same body mass index may fall into very different stages of ABCD, depending on the presence and severity of ORCD. Staging tells us how aggressive therapy needs to be. It does not determine whether a patient deserves treatment. Management, as outlined by AACE, is grounded in shared decision-making. The clinician partners with the individual to define personalized health goals while targeting sufficient weight loss to achieve specific clinical outcomes. Lifestyle intervention remains foundational, but AACE explicitly states that it should not be the ceiling of care. Pharmacologic and surgical therapies should be considered at any stage of ABCD when needed to improve health. Treatment selection should take into account complication severity, patient preferences, psychological comorbidities, social determinants of health, and access to care. Finally, the consensus reinforces that ABCD is a chronic disease and must be managed longitudinally, AACE recommends a clear plan for long-term follow-up to monitor maintenance of health goals, clinical outcomes, and the need for treatment modification over time. The key takeaway is simple. Obesity care, as framed by AACE, is not about chasing a number on the scale. It is about diagnosing adiposity-based chronic disease, staging complications, and treating ABCD with the same rigor we apply to any other chronic endocrine condition. This was another bite-sized episode of Endo in a Bite. Today's episode was an overview, and in the next few episodes, we will be working through the details of the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. Remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam prep. Let's get through this document one bite at a time.